Hi everyone, good afternoon. Ian Irving's my name. I'm ICON's Medical Director and also a clinical haematologist. This afternoon I'm joined by Dr. John Bashford, a hemato-oncologist who's also ICON Cancer Care's Director of Research. Today we're going to be going over some of your questions relating to COVID-19 and the immunosuppressed, particularly how COVID-19 interacts with cancer care. So John, thank you very much for joining us.
Thanks, Ian. Good to be here.
Thank you. And thank you everyone for watching. We very much appreciate the questions that you've sent in. Extremely helpful. Thank you. Our first question, John, is to explain to our viewers what ICON is doing to protect patients from contracting COVID-19 in our centres.
The short answer is a lot. The longer answer is this is a rapidly changing time. There are many recommendations. I'm sure you hear of them coming from chief health officers, from the Prime Minister, and we're endeavouring to work with our state health departments in every state in Australia to develop guidelines to improve how we treat our patients. We meet as clinicians regularly to update our policies. So we're working very hard to make our patients safe. The other part is also not just our patients, but our staff, because our staff, of course, are critical in the treatment of you or your loved one in this setting. So we're looking after our patients and our staff actively every day.
I notice going to some of our centres at the moment, certainly chairs in the waiting room have been spaced out to observe the government's social distancing policy. Are the clinical and treatment chairs being spaced out, and are patients being given masks at the moment?
Look, at this point we're not routinely using masks. The evidence is clear that the things that really matter are hand washing and social distancing. So the chairs traditionally are spaced in the treatment area because that's a requirement in our centres. But in our waiting rooms, we're increasing space. We're asking people to stay out of waiting rooms as far as possible. We're making contact with them so that they can come in at a time when they don't need to sit there for prolonged periods of time. We're doing everything we can to observe that social distancing rule. Essentially, the more space, the better.
Sure. Now, actually, quite a few patients and people have texted in their question about, I'm immunosuppressed, I'm on cancer treatment, does that put me at increased risk of COVID-19?
Look, I think what we know from the Chinese experience is that your chance of getting COVID-19 is probably increased. It's not as much as we would perhaps think, but there appears to be an increase, and it does appear to be more severe. However, the biggest risk factors are really complicated diseases of other types, respiratory disease, diabetes, and that big one, which is age. So I think if you're young and otherwise well, then your risks are much, much lower. But if you're elderly and fragile, then your risks are higher as well. So you need to build all of that into getting a feel for what your risk is.
Right. Following on from that question, Rebel has asked, what is her risk of COVID-19? She finished chemotherapy in June last year, and she's at present not leaving home unless absolutely necessary. She's 73 years of age. What would you say to Rebel, but also to others like her, about her risk of contracting COVID-19?
So essentially, this is less than 12 months. What really matters, Rebel, is what you were treated for and whether you're in complete remission. If you were treated for a blood cancer and you're not in complete remission, or you've had some form of immunosuppressive therapy that's ongoing, then you take great care. If you've had breast cancer and you've had chemotherapy and you're in complete remission, and that finished in June last year, you probably have a normal immune system for age. But remember, age is your big risk factor, and we're saying to people right around the country, if you're greater than 70, stay at home. Not only stay at home, but protect yourself against people coming in. I think we really need to look after our older patients, our older Australians. So you fit into that category, so there's special care needed there.
Yes, quite right. The other proactive step that a lot of people are taking. They've sent in questions around it relates to flu vaccination. Now, I would have assumed, John, that flu vaccination this year is more important than ever, that flu vaccination needs to be taken up by everyone, including those having treatment, their relatives and who they live with, plus the general population, so that people don't get a double whammy, if you like, of COVID-19 and flu vaccination and flu. Is that correct?
Absolutely right, and I think after many years of looking after patients with cancer, nothing suppresses people more than a good dose of influenza A. And to avoid influenza A is to remove one of the real risk factors that you can add. And influenza A is largely avoidable, or certainly you can reduce the severity of influenza by having the regular flu vaccine. The other important point of that is those around you should have it as well, because we're protected by our families. So families around you should have it, and you should have it.
Right. It's not just for the over 65s.
It's not just for the over 65s, and it doesn't cause influenza. It's a protein. It cannot carry a virus, and so it doesn't increase the risk of getting another infection.
You mentioned social distancing before, John, and the importance of social distancing in trying to limit the spread of COVID-19 in our community. With this in mind, are there some other specific things patients could consider at this time? In particular, should they be trying to have a phone consultation or a telehealth appointment with their doctor rather than attending the clinic?
I think consistently what's been recommended right around Australia is to use the telephone or use the computer as far as possible for a routine consultation. You know, there are some settings where you need to see a doctor, but there are many consultations that can be put off or dealt with using electronic methods, and the government's facilitated this. They've made it a lot easier to do. I actually think it's a really good step. It might teach us how to do this better in the future. We all know of going to the GP during an influenza epidemic and sitting in the waiting room. If we could change that over to telephone consultations, I think that's a good thing for health well into the future.
And you mentioned the federal government have set up these new item numbers. Will patients be out of pocket if telehealth or telephone consultation is performed by one of our doctors?
Certainly, in this emergency, the government have made what is very much a new rule, and that is that to use telehealth in this setting, you need bulk billing as the standard of care, and that means there's no out of pockets. I think it's a good step by government. It means that this is delivered immediately, and there are no barriers to its use.
Yeah, excellent, and it will certainly help us all observe social distancing and stop congregating in waiting rooms that will help us all as Australians fight the spread of COVID-19. Some patients are on immunoglobulin replacement therapy, sometimes known as Intragam or IVIG or IG therapy. Does this therapy help fight COVID-19, John?
No, sadly it doesn't, Ian, because Intragam works because it contains antibodies to all sorts of infections. If you need it, you should continue it so that you don't get all those other sorts of infections. But none of us are immune to COVID-19. Only those people who we know have definitely had it. And at this point, of course, they should not be blood donors, and so we don't expect to see those antibodies in Intragam. Intragam is in no way protective.
Right. Is there a vaccine available at the moment for COVID-19?
No, but look, vaccines, I don't have Dr. Fauci, the famous American infectious diseases immunologist, to contradict me, but as he did President Trump. But I can say to you that we have no vaccine, and sadly it's unlikely that we're going to have a vaccine for several months to well over a year. And the reason for that is, as it's complex to make it in the first place. As we know, we still don't have a vaccine against the common cold, and there are all sorts of reasons why that's so. But once we think we have one, we've got to see that it works, because not all vaccines work. And then some vaccines cause an over-brisk immune response and actually can cause harm. So it's really important that the clinical trials get done properly. But I can assure everybody that right around the world, people are working extremely hard. Our best intellects are working to try and get a vaccine, and I think that's the top of the agenda, because this disease will not settle until we get a vaccine.
No, very, very interesting. Tell me, John, we've got a few patients who've put in various scenarios. We know that every patient has a different cancer journey, but I mean, at the moment, someone's due for treatment, they have a sore throat, they actually don't have a fever, just a little tickle of a cough, they actually don't feel too bad. Should they be doing anything different? Can they come for their appointment? Is what I've described a concern for you?
Look, the first thing, Ian, is very much if you have any respiratory symptoms, then you shouldn't present to your treatment centre. We don't know, what distinguishes COVID-19 from a common cold or influenza in the early phases. It's a lot more obvious in severe cases, but in the early phases it may masquerade as any of those things. And so you're putting yourself, other patients and staff at risk if you come into the clinic. General practices, cancer treatment centres, hospitals all around the country are using telephone consultations to try and screen people out, fever clinics to have them tested, doing everything possible to try and make the diagnosis without people coming into centres where there are vulnerable people. So first thing is ring the centre where you're to be treated.
Yeah, no, thank you, John. As ICON's medical director, I can't reiterate enough the absolute importance that the whole organisation from the board down places on staff and patient safety. In the early stages of infection, COVID-19 is a very mild illness. In fact, in the early stages, 50% of people or more do not have a fever. So as John has said, if you have any respiratory symptoms at all, it is absolutely essential for your own well-being and the well-being of others, including our staff, that you don't just attend, that you ring ahead. John has gone through the fact that a telehealth or telephone conversation can be applied, and that will be far safer for you. Your treatment will still be able to be rescheduled. There will be a way forward, but presenting when you have a respiratory infection is certainly something we take very seriously.
Yeah, if in doubt, don't, I think is the answer at this point. Yeah.
What about if you're entirely well though and you're in self-isolation? You've returned from that New Zealand holiday in almost mid-air. The law changed and you're required to self-isolate on landing at the Brisbane airport.
Yeah, these are some of our most difficult issues, I think. We know that if you're self-isolating and you're well, your risk is low. It really does depend upon the circumstances. If you've come off a ship where half of the people have had COVID-19, then that's higher than if nobody has had it. So you look at the reason for your self-isolation. I think then the next question is, can you have your chemotherapy delayed reasonably for that 14-day period? There are many settings where you can. And again, I think it's really essential to think of your own safety. Having chemotherapy at a time when you're developing an active viral infection is something to avoid, and the safety of the staff who treat you. What you do want is those staff still to be there in a further 3 weeks' time when you're due your next course of chemotherapy. So I think stop, think, talk to your doctor, and allow a decision to be made. It's rare that you need to continue a chemotherapy course absolutely on a particular date. There are some circumstances, but they're less common. So talk to your doctor and make an informed decision.
So a few people have put that exact scenario to us, John, where they've mentioned that their doctor is considering postponing treatment or past the 14-day isolation or until they get over a cold. So your message is that does not mean the treatment will be less efficacious. That is not a bad thing to do under certain circumstances, postponing the treatment.
Certainly not. And look, all of the studies that tell us that chemotherapy works in cancers have always been done in the real world, where people get flus, where people can't make appointments for a variety of reasons. So you're another person in the real world. Those studies still apply to you, and there are other considerations as I've discussed. So take care. Talk to the people who can assist you.
Right. Now Liz has put in a question through Facebook. Thank you, Liz. If you're watching, we very much appreciate the questions, and it's going to apply to a lot of people, I think. Liz asks, my husband is post-stem cell transplant, now 3.5 years. Does he need to self-isolate?
Again, one of those questions for which there are a number of answers, and there are things to know. Firstly, if you had a stem cell transplant 3.5 years ago, and it's using your own stem cells, an autograft, and it's for something for which you are in complete remission, you've had no therapy since then your immune system is essentially normal, and you would treat yourself as you would for your age. If you're over 70, you take great care and you self-isolate because of the guidelines anyway. If you're 35 and fit and well, then it's reasonable. But if you've had an allograft, a transplant using donor cells, then I think the situation's more subtle, and I think you need to talk to your transplant physician. You may be in that setting where your risk is higher. And if you've had immunosuppressive therapy, Mabthera is the common drug, rituximab, that often goes for 2 years after a transplant, and people can remain immunosuppressed for several years after that. So again, ask your doctor what are the facts in your particular case. But in general, I think self-isolation for all of us as Australians is becoming the norm as far as possible, so keep that in mind as well.
Sure. If people need them, John, can some anti-cancer treatments be performed in the home?
Look, they can. It's interesting, Ian, you mentioned I've just come off a teleconference with the colleagues in Victoria, and we're discussing this. There are practical reasons why you might do that. The biggest issue facing everybody, I think, around the country with home therapy is that it takes more staff to deliver a certain amount of service. And our staff are limited. Trained chemotherapy nurses are a precious resource. And I think everyone views home chemotherapy with concern and caution, because it will reduce our ability to deliver therapy. I think there'll be special circumstances, but in general, it's not the favoured approach. We want to use our staff most effectively in these difficult times.
Sure. So if patients are coming into the clinic, then how should they attend the clinic? Can cancer patients still use public transport to attend appointments, or should they avoid public transport?
Again, a good and sometimes difficult question. I think as far as possible, avoid public transport. Public transport obviously means potentially being crowded in settings where you don't want to be crowded. And if you've got family who can drive you in, if there are close friends, if you can drive yourself, all of those things are preferable. If you find yourself in public transport for whatever reason, if you have no other alternatives, then try and avoid busy times. Use all of the things that we talk about, distancing as far as possible, cleaning your hands, using the hand wash that we all have as often as possible. I'm obsessive when I'm in any open situation now. And obviously avoiding those people with coughs and colds as far as possible. So you do your best, but ultimately better if you don't have to.
Yes, no, I think that. Thank you, John. Another transport-related question, and it reminds us that we live in a large state, and often
indeed.
people have to travel a distance from treatment. We have Karen, who has put in her question. I live in Western Queensland and travel to Brisbane for my chemotherapy for breast cancer. I've been flying to get to Brisbane. Travelling by car would require a few stops on the way and more risk with fatigue. What is your recommendation on how I should travel for my treatment?
Hi Karen, I've looked after many patients from far western Queensland, and I have great admiration for your ability to find your way down such long distances to have treatment. I think obviously one of the great things for us as a group in ICON is that we've spread treatment centres across Queensland to reduce the need for travel, but Western Queensland is always going to be a long way away. I think, again, I'd be talking with your doctor about the need for treatment. Can it be delayed somewhat? I think with what we're seeing with the developing pandemic, the time it's going to take for this to clear is becoming as clear as it's going to be at least several months. So chances are you're going to need to come down. I think as far as possible, flying is probably reasonable because people aren't crowding into planes. The biggest difficulty, of course, for you is will there be a flight? And then I think driving is the next step. But I understand it's very difficult to considering all of those things, managing a family, getting a car down here, not getting too fatigued. The other opportunity, of course, is if you have family and friends that you can stay with in close to your treatment centre. That's a good option. But I think it's a matter of making a practical decision with your doctor to work out what works best. The other possibility is, can we get a treatment centre closer to your home? These are all options I think that are being actively pursued around Australia at the moment. So I think I'd ask that question of your doctor. As you know, some of our colleagues in North Queensland have pioneered treatments closer to home in northwestern Queensland, and so there are a number of options that might become available to you.
Yes,
Yeah.
the teleoncology has revolutionised the delivery of chemotherapy, immunotherapy and other treatments in often more remote locations. So it's a very good point. And what you're saying too there, John, is that patients and their carers should talk with their doctor, have a telehealth or telephone consultation, talk with the treatment centre, work through the possibilities, because every patient, every situation is different.
Indeed.
I have another question here that I think you've answered before, but given the way the pandemic is coming out and what Scott Morrison and our other leaders have been saying, I think it's worth actually asking it to you again, John, and that is, as a cancer patient, should I be avoiding gatherings of people?
Look, I think the short answer is yes, and I think unfortunately we all have to be starting to do that. I think as a cancer patient, in general, as discussed, your risks are higher, and so you'd be even more cautious. I think as yet, not everyone in Australia has got the message about social distancing. I think increasingly we are, but I think aside from hand washing, the next big step is to avoid crowds, stay out of cafes, stay out of movie theatres, stay out of places where a lot of people congregate, particularly people you don't know who don't know what you're suffering and don't know the conditions that that you're going through, and so aren't able to judge how close to stand, etc., etc. So I think the short answer is yes. But look, we made a decision on the weekend to cancel our coffee after our cycling on a Sunday morning, and that's a big step after many years. But we all know as doctors that's the right thing to do, and so it becomes common sense.
Cycling without coffee, is it worth going for the ride?
It's a good question. I think the short answer is yes. Exercise remains good, and I think right around the world people are finding ways. You see great videos coming from Spain and Italy of people exercising in their living rooms and on their balconies and joining in with virtual exercise programs. So I think keep active is going to be really important for all of us through this.
Yes. Yeah, keep active, eating healthy, avoiding alcohol in excess. Exactly, good advice.
I saw a Spanish man who did a marathon on his balcony the other day, so there you go.
Let's hope he didn't need urgent medical attention.
Yes, indeed.
Okay. In that view of protecting yourself, would it protect patients if they wore a mask to the clinic? Are you advising when they come in for their treatment to our centres that they wear a mask?
Look, the general answer is no. The people who need to wear a mask are those people who are infected with some respiratory virus. But of course, if you're infected with a respiratory virus, shouldn't be there. So look, there's no routine policy, and general studies have shown hand washing remains the most effective way of avoiding infection. For the patient who's got a cough and who thinks a mask might enable them to come into clinic, the answer is no, you shouldn't be there in the first place.
Right. What about staff? At present, are ICON staff wearing masks? Is that?
Look, they're not routinely, although our chemotherapy staff, of course, have often worn face protection to guard them against chemotherapy splashes. And I think that's a form of protection. That's an evolving area. I don't think what I say today may be the same as what we're saying tomorrow in this regard. I think, again, the messages are very important around our staff, around hand washing and distance. But I think we're becoming increasingly aware of the importance of separating staff from risk as far as possible, because we want all of us as treating physicians, treating nurses, treating pharmacists to be there in the front line with our patients in 6 months' time. So these are questions that we're considering carefully, day by day.
This is a marathon, not
a
a sprint.
Yes,
marathon.
it is.
Whether on the balcony or out on the track, it's a marathon. ICON, of course, has 30 cancer centres in all 6 states, and also a cancer centre in the ACT. I can say as ICON's medical director to everyone that all 30 cancer centres are currently operational. There is no plan to close a centre at present. Our role and our commitment to the community through this COVID-19 situation is to continue to provide cancer care to the community, to offer the best possible cancer care as close to home as possible for you, our patients, bearing in mind that we want to keep you and our staff as safe as possible. So that is our mission, and we will do everything we can to uphold that mission. Could you go over, though, in a scenario for the viewers, John, what will happen if a centre has to close? So the people attending that centre, and they may have treatments booked in, as I say, it certainly hasn't happened yet, and we don't want it to happen, but none of us know how long this is going to go on for or how it's going to play out. If ICON has to close a centre for extended cleaning or just a lack of staff, with our staff being unwell or having other obligations, what's going to play out?
So at the moment, and as I said, I've been on a call with Victoria, and that was a national link-up to discuss these issues. There is a very active effort to link centres together, public and private sector, to ensure that people don't miss out with treatment. And we of course have a number of centres in major cities, and we've got the ability to move people around. So for instance, within Brisbane, we can move people from the north side to the south side, provide a number of options. There are public hospital settings that we can refer people to, and vice versa. We may find that public hospital patients will need to be treated in our centres. So doctors and health departments right around the country are working cooperatively in a fantastic way, really, to see that nobody misses out on treatment that they need. In an extreme setting, there are circumstances where decisions might be made to defer therapies that are regarded as less urgent, and I've talked about those different scenarios, but there are more extreme settings that we're seeing discussed, and we have to consider those, but we will have action plans right around the country, ICON and all health providers, to try and deal with those situations if they occur. So they'll be logical, well thought out, and we have time to develop them. Sadly, our Chinese and Italian colleagues are leading the way in terms of their experience. They give us a sense of what could happen. Hopefully, hand washing, social distancing will stop that from happening.
Yes, excellent. But cooperation between centres, and I can back you up there, John, and attest to that certainly there's a lot of cooperation between public and private sectors at the moment, and making sure people receive the treatment that they need. What about a patient who's unfortunately been newly diagnosed with cancer? Can people commence treatment at present? Is that still something that could be done?
Certainly, yes. Look, a patient presents today, the diagnostic facilities, the ability to have x-rays, to have PET scans, to have surgery, biopsies, pathology, all of those things are still there, they're all operating. And a lot of effort's being made across all sectors to ensure that people with urgent conditions will continue to be treated. And it does mean in some settings, and we know in Western Australia, that elective surgery for non-malignant conditions has been deferred, and there are obviously great inconveniences for people under those circumstances, but people with diseases like cancer will always be able to access treatment. And certainly at ICON we're doing our best to have our service continue to function in a non-interrupted way. It's in a different way, telehealth, waiting outside, distancing, but patients can still become treated.
yes. And I can give some examples actually even today where people have started off their course of chemotherapy because of an urgent need to have anti-cancer care, and absolutely, if that needs to be done, it will be done. That brings us to the close of our session. That's been 30 minutes. I know you all will join with me in thanking Dr. John Bashford for joining me to answer some of your questions and go through some scenarios with respect to COVID-19, in particular how it intersects with cancer care and the immunosuppression that we see with cancer itself and with cancer treatment. We have recorded today's session, and that will be put on the Icon Cancer Centre website, so you will be able to view our discussion at a later date. Hopefully this has been helpful to you. We may well do some more of these into the future, and certainly if you have any questions, please put them through the Icon Cancer Centre website, or if you are a patient yourself, never hesitate to call an Icon Cancer Centre or your particular doctor for specific advice that relates to your situation. So best of luck everybody, and stay safe.